Hi, my name is Beverly Ann, and today in our Safety Council meeting, we'll be talking about managing aggressive patients. So if we look at the literature, we see several important takeaways. Sari et al. 2023 found that in a single hospital, there were over 10,000 incidents of workplace violence against healthcare staff in over a 2-year period. Around 30% of those incidents were physical violence. We can also see restraints are frequently used as a primary approach to manage aggressive behaviors, which does have its negative consequences. Gertz et al. 2020 found that it disrupts the therapeutic relationship between healthcare providers and patients and also influences patients' decisions in their future healthcare. 40% of restraint-related deaths were caused by unattended asphyxiation during restraint use, which was found by Dua et al. 2017. Celofego et al. 2020 stated the guidelines recommend the use of de-escalation techniques as the first method of choice. And also Hawkin et al. 2013 found a reduction in incidence and duration of restraint after the use of de-escalation techniques along with other interventions. Now that we know what factors are important, I'm going to talk about the plan I propose to manage these kinds of incidents. Richmond et al. 2012 did a systematic review of the literature and found that across these studies there were 10 domains of de-escalation techniques. The first is respect personal space, so maintain that 2 arms of length and stay near the exits. Second is watching your body language. Do not be provocative. Hands should be visible. You should be appearing calm and non-confrontational. Third is that only one person should be establishing these de-escalation techniques. Remove the bystanders. Introduce yourself. Provide reassurance and be polite. 4 is to be concise. Use short, simple sentences, especially for patients who are experiencing delusions. Give them time to respond, and then you can repeat simple messages if necessary. 5 should be asking what the patient needs. Drink water, a snack. And then 6 should be active listening. Listen closely to what the patient is saying, clarifying statements, and accept what the patient is experiencing, and accept that that is their truth. 7 should be agree to disagree. There's going to be some things you can't agree on, so you might as well just agree to disagree with the patient. 8 should be laying down the law, but do this gently, as a matter of fact, not with aggression. So gently ask, I need you to sit down, or to help me understand, can you calmly tell me your concerns? 9 would be offering choices and giving optimism. So blankets, magazines, phone call a friend, food, drinks. Don't make promises, but also let them know the patient is going to prove, I want you to go home, but I want you to go home safely. 10 is debriefing with patients and staff. For staff, you can see what de-escalation techniques worked and what didn't. With patients, you can ask them, what can in the future can we do to help you when you're really angry? What works for you when you're very upset? These techniques can be demonstrated by anyone in the interdisciplinary team who's interacting with the patient during patient care. That includes PT, OT, physicians, security officers, anyone who's in patient care. This implementation will be over the course of 10 weeks. So in phase 1, we'll be teaching the 10 domains, conducting those educational sessions with everyone in the interdisciplinary team, doing real-life scenarios such as role-playing. In phase 2, we'll select one high-risk unit to observe over a 2-week period, and we'll place reminders for the de-escalation techniques in staff break room, posters in the bathroom, and then we'll do anonymous feedback boxes for all staff, emailed surveys for all staff as well to evaluate implementation. Phase 3s, we'll use all the lessons we learned from the pilot unit and then implement across all units, use those visual reminders everywhere across all units, do those daily huddles to debrief incidents and near misses, and then also monitor fidelity. Are all staff utilizing de-escalation techniques appropriately? Because that does affect our evaluation at the end. Phase 4 is evaluation and sustainability. Step 1 will be tracking and monitoring behavioral incidents. So we want to make sure, using data that's collected from incident reports and debriefing sessions, are we reducing the number of aggressive incidents? And then also, are we reducing the use and duration of restraints? Step 2 is surveying staff, assessing confidence and how often they employ de-escalation techniques, and making sure, are they adhering to these techniques? And then step 3 would be to review and implement future planning. We're going to do unit orientation onboarding with these 10 domains for new staff members, do performance reviews for staff, making sure they're adhering to the 10 domains, and then do monthly refreshers and in-service training for all staff members, making sure they're up to date. At the conclusion of our evaluation, our goal is to have a better understanding of how to handle these incidents in the future without the need of restraints and hopefully improving patient outcomes.